It is our endeavor to look back. History is always part of any learning process. So I would just go into history of heart failure therapies. Somewhere around, say, 100 years ago, the first failure therapy was digoxin. But the recent era of, say, evidence-based medicine started in 1986, where we have therapies, we have one and we have two started, and that we have to uh, I identified enalapril as one of the very significant therapy for reducing the heart failure. And these therapies goes on increasing uh, with more and more data available, with more and more molecules. Say, the lastly, we identified that beta blockers are useful, and mineralocorticoid receptor antagonists are useful, and ACE inhibitor ARB are useful in heart failure. So, heart failure, there are four types of therapy already reducing mortality, and digoxin was improving the quality of life. More and more molecule came into our armamentarium, but a very significant step came by name of paradigm HF in 2014-15. So a big step has come, and that is ARNI coming to our armamentarium. Paradigm HF trial was uh, largest available double-blind treatment period over a period of time with enalapril. Enalapril has been documented as a very significant uh, therapy prior to uh, ARNI therapy, and patients were enrolled with symptomatic NYHA class 2 to 4 with ejection fraction less than or equivalent to 35%. Probably they were stable for more than 2 weeks either on ARB or ACE inhibitor, and they were also receiving beta blocker. Uh, BNP was also followed up as follows. It should be greater than or equal to 150 or greater than or equal to 600 picogram. And of course, there were some exclusion criteria when we have ARB induced or ACE inhibitor induced angioedema, or if a patient has known hypersensitivity, or if a patient has serum potassium greater than 5.2 at the screening time. So ARNI versus enalapril, and ARNI was significantly reduced, reducing mortality as well as recurrent hospitalization rates in evident heart failure patients. The cardiovascular deaths were reduced, heart failure deaths were reduced, sudden death was reduced, and you can see everywhere the p-values were very significantly lower. So when we compare, go back to the data available, and when we compare probably ARNI over and above this ACE inhibitor ARB, over and above beta blocker, ARNI was reducing uh, heart failure death by 20%. Uh, that was very significant. You need to have 36 months, 32 months of standardized mortality reduction data. Overall, what was there was 32% reduction in the treatment of in the mortality reduction in the treatment of patients uh, post sacubitril valsart and combination. So, what is the effect? ARNI is superior to ACE inhibitor across all groups, whether EGFR was low, whether age was also a factor, whether ejection fraction was a factor. Almost everywhere, enalapril was inferior to sacubitril valsart and combination. So, across wide spectrum of heart failure patients, we identified this thing. Clinical efficacy of sacubitril valsartan in Asian individuals have already been identified. I don't go into details of this.